So let's cover some basic therapeutic protocol relative to the science of the 3 phases of healing. So we know there's the inflammation phase, the repair phase, and the remodel phase. So let's go into what are the common tests that we'll find and what would be the common therapeutic protocol, okay? So inflammation phase, and go through the categories of test. So we're going to have a symptom, right? We typically have symptom, maybe a sign, right? Maybe a structural observation, range of motion. Usually in the initial exam, you'll have a restricted with an active range of motion, won't you? In at least one plane, right? Okay. Overpressure, definitely, but not if you're not doing it. If you're not even doing it, you missed it. Muscle strength, usually there's some muscle weakness, but it's due to pain, right? It's due to pain. But it's still important and valid. Dermatomes or reflexes? Not really. Cranial nerves? Not really. Orthopedic test? Yes. Definitely the foraminal compression test, more of the overpressure test, things of that nature. Not typically the neurovascular test, typically. And then you go into palpation. Fixation? Yes. We almost find a fixation with new patients to some degree with because of muscular splinting and things like that with motor units. So remember, when we do palpation, we're paying attention to motor units, not gross range of motion. And when we talk about a motor unit, we're evaluating a motor unit's motion, and that's overpressure range of motion. Fixation is overpressure range of motion. It's not joint motion, it's not active range of motion. And then remember, you want to make sure you evaluate it in the plane of injury. Remember, everything you can have gross tests that are positive, but as it starts to clear up, bottom line is the motor unit in the plane of injury. That's ultimately, you want to look there anyway in the initial exam, but as they get better and better, everything else is going to start clearing up. That's going to be the last components to clear up is the motor unit, the biomechanics of the motor unit in the plane of injury. That's typically the last category to clear up, if it clears up. Sometimes it doesn't. It remains permanent at MMI. So you got fixation, then you got tenderness, yes, and you typically will have reflexive muscle spasms. That's typically what you'll be dealing with in a typical chiropractic patient, right? For the initial exam. Okay, what's a good therapeutic protocol? And remember, you can buy thousands and thousands and hundreds of thousands of dollars in equipment. That is not what we're talking about. We're talking about limiting the budget, being the most efficient with labor, space, and equipment. That still still helps. That's what we're trying to do. So could we come up with 10 different therapies to help with inflammation and pain? Sure. But now it's not even realistic in the real world because we have other real issues called budgets, time, money, labor. Okay? So having said that, we're pretty good at covering all 3 phases of healing on a real small therapeutic budget. We can cover all 3 of these pretty easily. So what's typically right here is the chiropractic adjustment. And then typically we'll use muscle stim and they'll use an ice pack at home. Now, what are some things you guys may be doing? Is there anything else you're doing for the pain and inflammation phase?
Cold laser and then the PMF.
So now you could go into cold laser. Now what do you got? What's the problem you have when you start doing things like cold laser?
It's expensive.
It's expensive, and what else?
It takes time to stand there and hold it.
Okay, so it could be labor intensive, right? Labor intensive, cost, and what else? You only have one.
Right.
So 2 people that come in need cold laser during industrial hours, what did you just do to your practice?
Because it's expensive.
You just killed it.
Yeah.
You can't build a practice with one therapy. That's like one of the common things I'm seeing now on Facebook. People are buying one expensive therapy, expecting to increase the revenue. I'm like, You can only do one patient now. What are you going to do when two people? And people, you can't have people wait. So that's the number one sign you're not going to grow, period. That's Mother Nature. Mother Nature doesn't naturally pour water into a full glass. It pulls it into an empty glass. You cannot have anybody wait. As soon as somebody's waiting, you are not growing your practice. So you have to look at one of 7 categories: space, labor, equipment, knowledge, skill, motivation, HR, and systems. You got to change one of those. Okay? So there's a lot of problems with stuff like that. You got one, it's labor intensive, it's expensive. How smart is that? What did you just do to your practice when you buy one expensive piece of equipment that's labor intensive? How smart is that?
Capped it, right?
You just capped it. You didn't increase your revenue, you just capped your revenue. So, anything else you want to use here? Anything else you guys use in here? Sometimes when I had acute patients, remember, most patients that come in are subacute re-exacerbations, re-injuries, aren't they? Most of them not are acute. I always say there's usually only about one patient a month that's acute. Acute meaning they couldn't drive in on their own. They had to climb out of the back seat, and had to be helped in. Okay? That's only one a month typically. That's not the norm. Most of our patients can walk in and out that front door. Okay? So, but every now and then I would use passive motion. If they were too acute, I would just start using passive motion that affects the nociception and the fluid movement. Yeah, you just start going a little at a time, and what happens? They start moving and moving further and further, and they feel better and better and better as you move, see? What is that? Gait theory, fluid movement, okay? So these would be real easy therapies, not expensive, not cost consuming. You're good for the inflammation phase, right? Okay, let's go to the repair phase. Now, again, what's the goal in the inflammation phase is to decrease pain, inflammation, and muscle spasms. So MS, muscle stim, will help decrease muscle spasms and pain. Chiropractic will too. Okay. Now we go into the repair phase. And remember, this is generally up to 72 hours, but it's not limited to 72 hours because we live dynamic lives, right? It doesn't stop at 72 hours. Now, if you were neutral and static and didn't move, that'd be it. The inflammatory phase wouldn't progressively continue on. It would just get better, better, and better. But do we live static lives? It's not even real. 72 hours in the inflammation phase is not even real. Does that make sense? Because we don't stand still all day. We move. Well, by the way, what's usually the number one problem with patients that prolongs or re-exacerbates problems? Well, prolongs healing and care or exacerbates problems. What's the number one typical problem with patients? No? They got to work. They actually have to do the movement that creates the irritation. That's the problem. How much quicker would patients go if they just got therapy and it didn't cause re-irritations? How much quicker? Way quicker. Okay, so the goal of the repair phase is to increase active, passive, and joint motion. Now remember, we know the physiology that happens in the repair phase. In hyperinnervation, reinnervation, increase the number of peripheral nerves into that injured area. The nerves fire at a lower threshold, and the nerves can get trapped in the scar tissue. The collagen or scar tissue is type 3 that comes in. It's only 70% is elastic, 70% is mobile. When does this start? It starts within a few days. So when I say this is anywhere from 6 to 12 weeks, does it not start until 6 weeks? Does this healing process not start to 6 weeks? No, it starts up here. So then why did I say 6 to 12? Is it past 12? Yes. So why did I say 6 to 12? That's the bell curve. But it starts earlier and it lasts later, and especially if you continually re-irritate the irritant, right? Then it keeps moving down the line. So what are the therapies that we want to use in the repair phase to increase active, passive, and joint motion? Well, chiropractic is the only That's the only therapy that affects all three ranges of motion, active, passive, and joint motion. And remember, out of all three ranges of motion, which one is the most important? Active, passive, or joint motion? Why? Joint motion is the most important because it's the fulcrum. The fulcrum to what? The fulcrum to the gate theory. It's the fulcrum to Davis theory, Davis law. It's the fulcrum to the laws of physiology. That's why. Where do all biomechanics start? At the fulcrum, overpressure, or active range of motion? Fulcrum. Fulcrum's everything. If I have a normal fulcrum, what's the likelihood I have normal overpressure and normal full active range of motion? What's the likelihood that I can have normal active range of motion, abnormal overpressure, and abnormal pathological joint motion? Real high. That's real high. So you see, if we focus on the joint motion with our diagnostics and therapeutics, excuse me, see if we focus on those, you can see we're impacting and affecting overpressure range of motion, active range of motion, and everything on a grand scale is what we're affecting. Okay, what else would we want to do here? Anything else you want to do here? Typical chiropractic types of therapies.
Some sort of resistance therapy.
What?
Maybe a resistance therapy.
Like what?
Like a TheraBand or something like that.
Okay, would that be for this or for
I
this?
guess it'd be more for,
This is remodel. So remember, the remodel phase has to do with the collagen trying to increase the strength and the elasticity. That's the remodel phase. So what else might we consider with therapy that affects active, passive, and joint motion? Would you say?
The PIR?
Say it again.
The PIR?
yeah, same thing as the PFS.
Reciprocal inhibition?
Yeah.
Yeah. Okay. That's good, right? Does that specifically, will that specifically affect active range of motion, reciprocal inhibition?
Yeah, definitely.
Will it affect overpressure range of motion?
Possibly.
Oh yeah, it will. You just saw it yesterday. We just did it on him. What happened to his head when I did it? It kept going further and further.
So overpressure.
I could move it further. When an external force can move it, that's overpressure. So yeah, will it affect joint pressure? Or not joint pressure, joint motion. Are we affecting joint motion with reciprocal inhibition?
I think so.
No, we're not. Are we going into joint motion at all? Did you see me go into your paraphysiological joint space yesterday?
Oh, right. No.
In other words, I didn't, did I? So you're good for 2 out of 3, aren't you? Okay. What's another real common therapy right here in chiropractic? Roller tables. Intersegmental roller tables. Passive range of motion. Motor unit, passive range of motion. How good is that?
It's really good.
Yeah, you've been on a good quality roller table. You get off, how much more do you feel like you can move? Does it affect nociception, pain?
Yeah.
Motor unit, yes. Motion, yes. Overpressure, yes. And if you're going to increase overpressure, will active range of motion naturally increase? Yeah. Yeah. Intersegmental roller tables are really good. What's the problem with them? They're expensive, take up a lot of room, don't take much labor, do they?
No.
They're passive.
Yeah.
Patient can even turn. We had our patients turn them on, and it clicked off on its own, and we trained the patient to turn it on.
There you go.
So it didn't take much labor. They definitely cost. Now they're like $3,000, $4,000 a piece, and you can never buy one piece of equipment. Do you get that now? As soon as you buy one piece of equipment, what did you just do to your practice? You just capped it. Because soon as somebody's waiting, you just limited your practice. So, what's the other problem with the roller tables? They take up a lot of space. You know, I did have roller tables in my office. We did do that. We had 6 roller tables. That was a big room. We had a big room. We had 3 this way, 3 this way, and you could walk down the middle. I mean, it was a big room. It was probably a lot like this room. This is a pretty big room here. Okay. Do we recommend that? Do I recommend that especially with new clients who are on a budget? New guys out of school? No way, Jose. So we can go in a lot less space if we don't have tables, therapy tables, can't we? Because it's the therapy tables that take up a lot of space. So, anything else that happens here? What's the best thing to do in the repair phase right here that affects active, passive, and joint motion? Chiropractic adjustment. That's the best thing. Then you come over here to the remodel phase. Now we want to increase the tissue strength and elasticity. How good is reciprocal inhibition for this? It's fantastic. What else? Now remember, we got to consider what? Space, labor, and equipment. Because we can go out and buy $50,000 worth of gym equipment, right? No. Can you see what a nightmare that is right now? Sometimes I walk into an office and I'll see 6 or 7 gym units. I'm like, oh my God. What does that tell me about their overhead immediately? Skyrocketed. Does that take labor? Yeah, labor, management, space, cost. Whoa. So reciprocal inhibition, is that cost? No. Labor? It is a little bit more labor intense, but we'll do modified. We won't do the full 15 minutes. We'll do modified if we do it. But it's a very effective cleaning. And I don't have to do it. I can have my assistant do it, right? So I can leverage my time off, but it's still a little more labor intensive. What else?
Adjust for elasticity.
The TheraBands. Well, remember we're working on elasticity. Well, we're already done with the adjustment here. The adjustment definitely helps for elasticity. Yeah, you're right. Yeah, definitely the chiropractic adjustment. Does that chiropractic adjustment help with elasticity? Oh yeah. You have a fixation, you get adjusted. How quickly can you move more? Immediately. Okay. So TheraBands. How inexpensive are TheraBands? That unit right there costs what? $100? $100. That TheraBand station costs $100. You want at least a minimum of 3 stations. Remember, because you can never have one. You at least need 3 to see like over 100 visits a week. Okay. How much space does that take? It doesn't take any because it's all dropped against the wall when it's not even being used.
But people take space.
So if you only had 3, you could see 100, 120 visits. If you had 4, you could see like 150. If you had 5 or 6 units, you see over 200. And I'm talking about with nobody waiting. You have 6 people on there at the same time, see over 200 visits a week during industrial hours and nobody waiting. So that's what I say. Yeah, if you want to see over 200 visits a week, you need 6 therapy stations. If you want to see over 100, you need at least 3 minimum. And you want 4 if you want to see like 150. That's kind of a general rule. Yeah, I go into chiropractors' offices all the time. I went in one time. Guy had 1 therapy here. He had 2 therapies of this 1 therapy. He had 1 therapy of this, 1 therapy, and 1 therapy of that. How well was he doing in practice? It was a sad story. 60 visits a week, and he'd been in practice 40 years. You know how much money he lost in 40 years by only seeing 60 visits a week? He was in about 800 square feet. And to be honest with you, one of the reasons he even made it, he didn't have labor cost. Why? His wife was the CA. So he had real low expenses. Otherwise, he wouldn't have made it. If he had labor cost and any kind of overhead at 60 visits a week, that's not good. That is not good. Because usually your first 20 to 40 visits are 100% overhead. They go to your fixed expenses. So we went in there, and what's the first thing? And he was losing patients. He was losing over 50% of his patients by the 6th visit. So what did we do? Went into patient education. But I said, as soon as you do the patient education and you keep them, you just shut your practice down. Why?
Because you're capped.
there's no place for them to go. I say you got to get rid of 4 out of 5 of these. You've got to get therapies for the repair phase and the remodel phase, and you have to have a minimum of 3 units to be able, because the retention's going to work. He's going to go from 60 to 100 visits in 60 to 90 days. But he needs them to be able to go somewhere. He needs them to be able to get on a therapy. Okay. Anything else here? Sometimes there's the cervical traction. What's the good and bad news about the Pedibond cervical traction? What's the good news? It's inexpensive. Space. What?
It's effective.
Effective. Well, we're going to say everything we're doing is clinically effective. We're not going to challenge that. So I'm talking space, labor, equipment.
Yeah.
So space is good.
Labor intensive.
This is labor intensive?
You got to set them up. You gotta strap them.
No, it's not labor intensive. You're just setting them up and walking away.
Okay.
They're doing it all on their own. It's not labor intensive. Labor intensive is when you have to sit there with the light laser. I watched a guy on, did you guys ever do ultrasound therapy?
Yeah.
How fun was that? How fun was that going like this with a patient for 5-10 minutes?
Keeping the gel on. Yeah.
Do you feel brain dead? I felt brain dead. I'm like, are you kidding me? This is what I want to do with my life? And then they even stopped paying for it. Initially, in the clinic, I had ultrasound. And I'm like, this is what I want to do with my life? Sit here and wave a wand? Who can wave a wand? An 8th grader can wave a wand. And he's on Facebook waving this wand with a laser. I'm going, oh my God. You talk about brain dead labor. Brain dead labor. Limited. Can he do anything else? Nope. Expensive? Yep. How many units? 1. You talk about capping a practice and being miserable. Anything else here? Oh, this Pedibond therapy. Space, great. Labor, great. Cost, great. Okay, what's the problem with it?
Patients get confused with it, maybe?
What?
Maybe patient confusion?
No. Well, that's your bad communication if there's patient confusion.
Yeah, I don't know.
Huh?
I don't know the bad way.
It's only cervical. It's only cervical. It's not lumbar. So you're limited to cervical, right? Which is okay if you want to apportion that into your practice, right? It's okay. So you might have like 3 TheraBand stations and maybe at least 2 Pedibonds. So at least 2 people can do it at the same time, right? So you maybe, I always say a minimum of 3. You want to see 100 plus visit, you need 3 units of therapy. So it's cervical. Same with the Pedibond chair, the portable wobble board, the Pedibond. Okay, and actually that's pretty good because it's your whole core muscles, right? It's affecting your whole core muscle group. Proprioception, core muscle group. Space, how much space does it take? Very little. It goes in a chair. Yeah, it's a little Pedibond. You sit. It almost looks like a saddle. No. It looks like a saddle. You set it in the chair. You just set it there, and then the person sits on it, and then they're sitting on it. It's not their head.
Well, no, I mean, that's what
And then-
sometimes do.
And then they're going forward, back, left to right. So, space, great. Labor,
Awesome.
awesome.
Patient does it himself.
Teach them how to do it, and they do it.
Yeah.
Labor, space, labor, equipment, easy, good. Pretty good, isn't it? Pretty therapeutic for the whole core structure, right? Pretty good. So that's looking pretty good. TheraBands looking pretty good. And cervical traction pentagon if you want to add a few units for just cervical. By the way, in a typical chiropractic office, what percentage of your patients would be cervical versus lumbar? If you had to guess.
40%.
40% cervical? Is that what you think?
Mm-hmm.
What do you think?
Probably a third cervical.
Okay. So you'd say at least 50% or a little more is lumbar, right? And a little less cervical. Okay. Unless you just had a personal injury office, right? Most personal injury is mostly cervical, not as much low back.
That's fair.
Yeah.
It seems the younger kids are getting more neck issues.
Yeah. Okay. So if we were gonna put a therapy in this office, how much would this cost? We got chiropractic covered. Muscle stem could be used. What could be used for muscle stem? The TENS units. How much does a TENS unit cost? $30 to $50. Inexpensive ice pack at home. How good did we just do with cost, labor, and equipment with the inflammation phase? Can you see why it takes us less than $7,000 to equip an office fully with new equipment? And that's not $7,000 toward therapy. It includes therapy, the adjustment table, at least 3 units, and then it includes the computer, bookcase, shelves, posters, chairs, plants. $7,000. Okay. This is mainly chiropractic, right? We're not going to do the roller table. Is there anything else for active passive joint motion? Come over here, we got reciprocal inhibition. There's no cost there, but it's little labor intensive. And then we got the Pedibond standing still or the TheraBands. TheraBand's $100 a station, 3 stations, $300, $600.
I just realized you're a lefty.
See? Bottom, Pedibond. These are, I think, about 150, 180, I think, is what these are. Have 3, so you're about $400 to $500 for 3 units. So you're about $600, $800 for 4 units, roughly. So this was, if this was, say, 600, TheraBand, let's say 400. We don't need anything else we need here. TheraBand, Pedibond. Do you want to add anything else in here? TheraBand. I mean, you could just do TheraBand and be totally fine, right?
Yeah.
Okay. Come over here, chiropractic. How much? $50 per muscle stem. So you say 2, 4, say 2, 4, say $300 for 10 units. $300, $400, $600. Equipment, $1,300 to cover all 3 phases of healing: inflammation, repair, and remodel.
Other than 2.
There's no tables here. These are chairs.
Oh, well,
Yeah, just
This is therapy equipment only. Can you see now? I add a computer, right? Bookshelf, desk, chairs, posters, plants, a few accessory office products. I'm under $7,000 and it's all new equipment. That's how we open offices for less than $20,000.
X-ray would be a separate.
No X-ray at all. We don't start with X-ray at all. Don't want that expense. Just we refer them to the local MR center. A lot of the insurance companies don't even pay for it anyway.
Yeah.
Or if you're in a major city, they contract with the local MRI company. They won't pay for chiropractors if you're in a major city, if you don't know that. So really, I mean, X-rays are only worth it if you're doing a lot of PI, to be honest with you. Otherwise, we don't use them at all. We send them over 50% of the offices we open now. We don't use that. We don't have X-ray in house. It's way easier to send them out. You know how much it costs us typically for an AP lateral flexion extension type view at an MRI center? $70. I'm talking all 4 views. $70 typically. All 4 views. And you know what kind of quality they are?
It's crisp.
Way better than chiropractic quality.
Crisp, yeah.
And they're read. They're professionally read.
Right.
Now they're not read for biomechanics.
No.
I do have a chiropractic radiologist that will read the biomechanics. and they're only $25 to read it. So this is real expensive for proposition. So we just refer them out. Patient leaves our office, they go to an MRI right after the first visit. We get the x-rays back the next day, or they'll go in the morning before work, or after work, they'll go get the pictures. So there's 3 opportunities for the patients to bring those x-rays back, or us to get them back in a portal before we see them on day 2, before they come back on the next day. we're ready to go. See how it works? So we can go into, and then if the office is laid out real well, there's 3 types of office layout. One is if you divide everything up. That's the worst kind. Separate rooms for treatment, separate rooms for therapy. It's the highest cost, lowest overhead, less efficient. Highest overhead, less profitable. Then there's the hybrid. You do the treatments in separate rooms and the therapy is together. That's the second best. And the absolute best, highest profitable, lowest overhead is the adjusting area and the therapy area. It's combined space. You're not wasting. This wastes a lot of space. Every 90-degree angle, there's a certain amount of square footage that's totally wasted, 1.5 feet out, all the way to the floor. Totally wasted space. And usually the last third of a room, when you go into a room, the majority of the space you use in the room is the first third. The second majority is the second third. The last third of the space of a room is the least used space in the room. Usually it's wasted. So we can actually go into 800 square feet. I started my practice in 800 square feet. So especially when you combine the adjusting area with the therapy, now all I need is a real, and we don't do large waiting rooms. We only put 2 rooms in the waiting room, 2 chairs in the waiting room, because that's one of the highest wasted space areas. Because remember, our office is designed where nobody's waiting. The only reason they're in the waiting room is what? Fill out the initial paperwork. That's it. Every time they come in, our whole office is designed for them to come back. If they can't come back and go into the adjustment, they come back into therapy. If they can't do that, we got chairs waiting for the adjustment, and we got chairs waiting for the therapy. Because here they're not waiting. In the waiting room, they're waiting. Ready to go. Because that's what they want. They want to be ready to go. They want to get in and out. So that can easily be 800 square feet. The only thing that I need is 1 room for an exam room, just some semi-privacy for report. I'll typically have 2, so I can do 2 simultaneously, and I can have 1 or 2 associate doctors in that office. But the typical office is 1,200 square feet, give or take 200. So it's either 1,000 to 1,400 square feet. And that's with 3 doctors when it's laid out like this. You can have 12 to 1,400 square feet, have the other rooms. The doctor's room, all 3 doctors are in the same room. Me and my 2 associates were in the same 12 by 15 room. We just put a counter against the wall, and we put bar stools right against it. We all had our stations. We didn't have big, fancy. It always shocked people when they visit my office. I had 77 offices in 20 states. So guess what kind of office they expected to see? They expected to see a big plush leather seat, huge mahogany desk, and no. Because I'm wasting time sitting in that chair. I'm not making money sitting in that big chair, and I'm wasting space. I was in a 12 by 15 room, and we took a countertop from Home Depot, and we put it against the wall, and I had bar stools for the chairs. Why bar stools? Bar stools that were cushioned. Why bar stools? Bar stools that turned. Number 1, so we wouldn't get relaxed and sit there, because you know how it's like. When you sit there and get relaxed, you don't want to get up and see a patient every 10 minutes. They're bar stools, so when you sat on it, your core muscles, you had to pay attention, you had to stay up, and you could easily slide on and slide off to see patients. Not sit back in your big plush chair and doze off. That's when you don't want to see patients. It's counter to seeing patients. That's a prohibitive factor to see patients. You set yourself up to not want to see patients. And then everybody had their computer station, and we had phones in between. If you poked your head in there, you wouldn't have known which desk was mine or theirs based on authority. So there you have it. 1,400 square feet, 3 associate doctors, seeing 350 patient visits a week. High efficiency, focused just mainly on the neuromusculoskeletal spinal. We didn't chase all these other things. We had 6 therapy stations. We did chiropractic, muscle stim. They did an ice pack at home for inflammation. We did chiropractic. I did have roller tables. We did have a big roller. We don't do that anymore. And then you do the TheraBands. We did a little PNF. Our therapist did a little PNF. But if you just do the TheraBands, you're totally fine. You don't need anything else. And if you wanted to add the wobble board or TheraBand or servo, you could. But you would be totally fine with a little bit of resistance with a $100 station of TheraBands. 350 visits a week, 2 associate doctors. In a town of 3,000 with 2 other chiropractors. Those chiropractors were in 60 to 80 visits a week. Why? Because they didn't know marketing, they didn't know business. I knew marketing, I knew patient retention, I knew educational sales, I knew personal injury. So I had way more business than I can physically see with all our doctors. So I was training, that was our office, and I was training 7 doctors every 6 months. So my office was actually 1,700 square feet. So I had another separate room just with 6 doctors in there for training. And every 6 months we opened, not 6 doctors, 7. Every 6 months we opened 7 offices. Next group came in, we trained them. Opened them. Next group came in, we trained them, opened them. It's all about training. Got to know the knowledge, because remember, knowledge, books, seminars, and tapes will just take you from unconscious incompetence to conscious incompetence. That's the problem with seminars, books, seminars, and tapes. To get from conscious incompetence, in other words, you know it, but you don't know how to do it, to conscious competence, where you can do it, but you're not real good at it, that's role-playing and training. That's sensory and motor. That is what is most important to get from point A to point B. Most time, if you don't do any training, you'll never even get there. You got to train your staff. You have to know how to be a trainer. Got to train your staff, got to train your doctors, got to train yourself. This is how I train myself. When I'm doing something, I know how to go through those 4 stages. And I know a mentor is the best person to get me from point A to point B with training. That's the fastest, quickest place to get from point A to point B, wherever it is, whatever it is you want to do. When you get to conscious competence, it's when you kind of can do it, but you're not good at it. Now you need repetition with discipline. That's what takes you from conscious competence to unconscious competence, black belt. That's the 4 stages of training. So clinically, this is what I'm going to start with. When am I going to start the rehab? The active as fast as possible. Now here's the real question right here. Can you see that? I'm starting the remodel as fast as possible. We're doing the adjusting as fast as possible to start effective, active, passive. Okay, here's the real question. This is the real question. When are you going to start rehab? Are we going to wait 6 weeks, 12 weeks to start rehab? No. We want to start as fast as possible, but what are the clinical limiting factors with rehab?
Pain-free motion.
Pain-free motion. What happens if the patient does not even have pain-free motion and you start putting resistance in there? You got problems. You're going to delay it. You're going to increase the injury. It's not going to be pretty. Exactly right. So we like to see the patient, at least whatever the injured area is, the neck, the back, whatever, we'd like to see them to be able to go through that full range of motion, pain-free, then start adding some resistance. And what did I say? The bare minimum resistance that at least we'd want to do?
5 pounds?
2 re-exams. From one re-exam to the next. It's the bare minimum. How often should you do re-exams?
12 visits.
Every 12 visits or every 3 months, whichever one is sooner. So in the first 4 to 6 months, it's going to be 12 visits. 6 months, 8 months, a year later, you're not going to be seeing at that as much of a frequency. So when you don't, it's every 3 months. That's typically not relatable to chiropractic. So usually it's every 12 visits in chiropractic. And then I'm going to look at them. And when am I going to stop the therapy? When am I going to stop that active therapy? So I do one re-exam to the next. When am I going to stop the rehab therapy? What's going to be my indications to stop the rehab therapy? They've plateaued. They've plateaued in the remodel phase. I know that's it. When they've plateaued from one re-exam to the next in their test, in other words, there's no more changes. And they're in the remodel phase. Because if they're here, they still have opportunity to heal and grow, don't they? So when they're in the remodel phase, when does the remodel phase start?
3 months.
3 months, 3 months after. So your patients should be in the remodel phase. There should be 2 re-exams in the remodel phase, that plateau. That's when they're at, defined as what? MMI. MMI, maximum medical improvement. Because if you do it here, you're not giving them the full opportunity to heal, are you? That's how it works. How much sense does this make? And it's fantastic for patients. It decreases the pain and inflammation as fast as possible and increases the active passive joint motion. We're going to pay attention to, with all our tests, we're going to narrow our tests down and pay a lot more attention as this moves on. Because remember, what's going to decrease or get back to normal the fastest? The test in neutral position. So we're going to pay a lot of attention to dynamic tests, number 1. Number 2, in the plane of motion, in the plane of injury. And what's number 3? The motor unit. How am I going to be able to evaluate the motor unit most accurately? Motion x-rays. What else? Fixation, tenderness, x-rays. Are those not the top 3 for the motor unit? That's the absolute pinnacle of spinal care, is looking at that motor unit when? In the remodel phase. Where? Plane of motion of injury, motion, plane of motion, in the remodel phase at 2 re-exams. How much sense does that make? That's what quality care is based on. Now, you need to know how to convey that to patients. That's called patient education. And then you need to know how to make it affordable. And we make it affordable. And then you have to be able to respect their time. In other words, when they walk in that front door, they're not waiting. They come back and either get treated or they get the therapy. One of them starts pretty fast. And they're out of your office in no more than 20 to 30 minutes. Because they're coming back 2 or 3 times a week, especially to affect the collagen and the piezoelectric effect. They don't need 2 or 3 times a week for the gait theory, do they? That happens instantaneously, right? That's why they feel better. Statistics show chiropractic patients feel, 1/3 of them feel somewhat better immediately on the first treatment. That's the statistics. So gait theory happens as soon as you adjust the patient. So if it was only pain in gait theory, do you need to bring them through all 3 phases? No. You could just stay in the inflammation phase and that's it. But then what are you allowing the patient to do in the remodel phase? Heal wrong. What are you allowing them to do in the repair phase? What are you allowing them to do in the remodel phase if you don't have therapy here? You're definitely allowing them to heal wrong permanently the rest of their life with increased numbers of regenerative nerves, nerves that fire at a lower threshold, nerves that get trapped in the collagen, and then the collagen, type 3 collagen is not as strong, so they're going to be more susceptible to re-injury with their activities of daily living, and they're going to be stiffer and not have as full as motion because the type 3 collagen is only 70% as elastic. All because you did not do this or this. To some degree. Now, this could be subthreshold, right? Subthreshold meaning it's not affecting their sensory or motor. But you know it's happening anyway. The question now becomes, how many times is that going to happen before it now becomes threshold? How many times do people have one little injury and it's no big deal, right? Now you add 2 or 3 little injuries and now what do you got? It's the onion effect. So this is still happening even if it's subthreshold. So you think you might want to do the therapies here still knowing physiologically this is what's going to happen? Yes, because you're trying to minimize this as a physician. You're trying to minimize the permanency and the residuals of this from happening and decrease this from happening. And so you're trying to decrease the potential layers also, not just that one incident or accident, but also any layering effect. You're trying to decrease the magnitude of the layers that happen with these injuries. That's why when new patients come in with permanent injuries, they already had permanent injuries, but they had a re-injury. Is the re-injury going to go through the 3 phases of healing? Yes. So will I still take that patient who had previously permanent problem, but they had a re-injury? Will I still take them through the 3 phases of healing? Yes, because the new injury is going through the 3 phases of healing. But wait a minute, they already have a permanent problem, so why am I doing this?
You don't want it to be more of a problem.
That's right. I don't want it to be more of a problem. I'm trying to decrease the layering of the permanency. And I tell the patient that. When I have patients on day 4 that are permanent, I tell them, you got a permanent injury. Here's what we're trying to do. The goal of the therapy is to decrease the magnitude of your permanent injury now. That's what we're doing. Any questions about that? Any questions about what therapy to use and why and when?
Nope.
So the real question, this is easy, right?
Yeah.
This is relatively easy, right?
Yeah.
The real question here is when you start this as fast as you can based on what?
You're reading that.
Range of motion, pain-free range of motion. That's the real key.
But you're going to do that at the re-exam, or you're doing that every time they show up to your office? The active re-exam.
Re-exams are what determine a new diagnosis or therapeutic protocol. Re-exams.
Yeah.
When patients come in for regular visits, what type of biomarker should you check?
Range of motion.
Well, based on Medicare guidelines and third-party reimbursement and UCR, usual, customary, and reasonable, that's called a SOAP note.
Right.
So subjective's pretty easy to get, isn't it? Right? What's the problem? Scale of 0 to 10. But remember, I told you, if somebody comes in and they say 3 or less, 3, 2, or 1 or nothing, what did I tell you to do? Ask about it in the dynamic plane, not the neutral. Because when they say 3, 2, or 1 are normal, they're telling you in what plane of motion?
Sitting or laying.
Neutral.
Yeah.
Neutral. So you have to, this has to register with you and go, boop, light goes on. They said 3 or less. Let me ask you about that problem, whatever it is, neck pain, back pain, whatever. And then you direct it in the plane of motion, whatever it was, and you should know that based on the re-exams. Which plane of motion did they have the most trouble with? Say, well, what if you took your neck back and bent it all the way back as far as you can? Now what would it be on a scale of 1 to 10? That's how you get the dynamic subjective complaint. Are you with me? Okay. All right, so that's that. And then you move them into, you're already moving him into chiropractic, and then you want to try to move him into rehab as fast as possible, but I don't want to do it unless I have that. So the question is, what do you do for a SOAP note? Well, I just told you the subjective part. Medicare requires 2 E&Ms, right? 2 evaluation and management. Well, you could take blood pressure again if you wanted to, right? What's the relevance of blood pressure to altered pathological spinal mechanics problem?
Nothing.
It'd be a stupid test to do, wouldn't it? But it would qualify for E&M, wouldn't it? You get my point?
Yeah.
Okay, so having said that, what are the highest probability, highest sensitivity test relative to the typical chiropractic spinal injury, mechanical injury patient?
You do overpressure. Active range of motion.
Palpation. Palpation, fixation, tenderness, muscle spasm. I just gave you 3. I just gave you 3. So yes, I'm going to palpate the patient in a regular visit for the objective, because I need 2 E&Ms. What E&M has high probability? Joint fixation. That's a motor unit overpressure. That's high probability, high sensitivity, high relevancy. Is that a good test to do for a typical spinal biomechanical problem? Yes. And then you do what? Quantify it. How are you going to quantify it? 0, 1, 2, 3. Functional capacity index. 0, normal. 3, you do it and they stop you from doing it. 2, you do it and they try to protect it. 1, you could totally do it and it's tender. There's your grade quotient. Because they should be what at MMI? 0. 0 is what they... And we're testing them in dynamic motion. When you're testing a fixation, it's dynamic, right? We're testing it overpressure dynamic motion, not static. And then you're going to quantify. That's one. What's another one? Tenderness. Now you could be done right there, right? We got our 2 E&Ms. We're done. We've qualified for the standard of care. Okay? What's the likelihood somebody's going to be tender if they have a fixation?
Always.
Almost always. Do you want to grade the tenderness?
Yes.
Yes, you want to grade every biomarker. Okay? So how would you grade that? You could just grade it the same way, functional capacity. You could even ask the patient, say, is that tender, Mary? Would you say that's more mild, moderate, or severe, Mary? Right? You could do that. But definitely quantify that tenderness. Whatever you do, stay consistent. Don't do mild, moderate, or severe one time and then scale of 1 to 10 the next. Right. Just whatever you're going to do, quantify it and stick with it.
We said 1 to 10.
Okay.
Right?
Now, I just do muscle spasms also. Because what's the likelihood they have intrinsic muscle firing?
Very.
Yes. And it supports the need for care too. It's diagnostically sound, it's high sensitive, it's high probable, and it establishes the need for care. And it's a secondary reaction to altered motor unit spinal biomechanics. See how much sense this makes? Or would you rather just check their pulse and blood pressure? You get my point? And how quickly can we do fixation, tenderness, and muscle spasms, unilateral, bilateral?
Simultaneously.
7 seconds. Sit right here. Tender? Yeah, right there. Got it. I'm done. That's how fast I completed the objective portion. That's what you do for the typical daily visit. Now, am I going to change my therapeutic protocol based on a daily visit soap note? No. It's comprehensive. It's the full re-exam compared to the last re-exam. Okay? Is it as valid if you're only going to look at one exam to change therapeutic protocol? No. I want to see its relationship to the previous exam. That's going to be a major factor. Is the patient getting better, worse, staying the same? And then I'm going to go, well, what phase of care are they in? Do I need to start doing some other therapies like active therapies, passive active therapies, or resistive therapies now? Can they handle it now? Are you with me on this? There you go. There's your clinical protocol. It's all based on what? The science of the 3 phases healing relative to the patient's biomarkers, and you're going to pay a lot more relevance to high sensitivity, high relevancy biomarkers, dynamic biomarkers in the plane of the injured motion. And what's the very last biomarker? So when we look at all these biomarkers, we go subjective. We want to make sure we get that in dynamic, right? Tenderness, dynamic. Nerves, typically we're not going to have a problem with that, are we? Dermatomes, reflexes. Orthopedic test, which ones are going to be the last one to clear up?
The plane of motion injury.
Plane of motion injury in all 3 ranges of motion. In overpressure.
Right.
In the neck, that's foraminal compression. In the back, it's Kemp's. That's the last test. Secondary test will clear up first. Will shoulder depression test clear up before foraminal compression for facets? Yes. Do you need to know this?
Yeah.
Yeah. You should be following this and looking for this. You shouldn't just be doing tests and wondering what they are and write it down. You should be looking for it and guiding for it and knowing what to look for. So that's the first four. The next one is range of motion. We're going to pay attention to active and passive. Active will clear up before passive. Passive will be one of the last ranges of motion to clear up in the plane of motion. I already know that. I'm going to pay attention to it when I do the re-exams. And then I'm going to quantify it. Then I'm going to check muscle strength. Muscle strength will start getting back to normal, won't it? If they have pain initially, it'll be a grade 4, right? So as soon as it's back to normal and you test the muscle, as soon as it goes back to grade 5, that should be another red light for you, and you need to now test what? Put your finger, thumb on the spinous process of the motor unit of the lesion and retest that muscle strength. You heard of AK, right?
Yeah.
You've seen where they touch you, they test your muscle. Have you guys ever had AK done to you?
Yeah.
Has it not been accurate or what?
It's been pretty wild.
It's pretty accurate. You ever had them not test you and then not push on you and then test you and push on you on the lesion?
Yeah.
Is it night and day or what?
It's different.
Because it's true physiology. It's not hocus pocus. So if you get a normal test, especially at MMI, muscle test, and especially if you have a personal injury case, what better you do? Because should they not have 100% strength when you push on the spinous process of the motor unit relative to that muscle group, if they were 100% healthy? Should they not have 100% strength?
Yes, they should.
Yes, they should. But how many of them actually don't? Here's the reality. In the beginning, they'll have a little bit of muscle strength, especially in the plane of motion, grade 4. It clears up pretty fast. Muscle strength gets back pretty fast, usually by the first re-exam, almost always by the second re-exam. As soon as you do that, at MMI, you better retest that muscle, push on the motor unit of the associated muscle group you're testing, C4, C5, whatever in the neck, retest their muscle. Pay a special attention to the plane of motion muscle test when you test. That's the last test to clear up muscular-wise. Is it not?
Yeah.
It's dynamic, it's in the plane of motion, and you're challenging the neural response. Are you with me? How much sense does this make? Did you hear this anywhere else besides me? Have you heard this anywhere else in chiropractic besides me? Have you seen anywhere in chiropractic somebody put the 3 phases of healing together with the therapeutic protocol and why you're doing what you're doing scientifically? Have you ever seen this before?
Never.
And that's sad you've never seen it before, isn't it?
It's unfortunate.
You should be able to teach this before you graduated, shouldn't you? Okay. So that's muscle. We got active muscle. Next common biomarker is neutral X-ray. I will look at their neutral position, but it's not going to be as important to me. But abnormal hyperlordosis, that's not good, right? We know that's going to cause some problems, wear and tear. Degenerative X-rays. So neutral X-rays I'm going to pay attention to. Physiological line of stress, McNabb's line, lordosis. It's going to play a role. But what am I really paying attention to? Motion. What's the most common motion X-rays we're going to pay attention to in the neck? Flexion and extension. What are we looking for in flexion and extension? Translation. Do we have ligament injuries? Are those bones moving 1 millimeter or greater when the patient moves? That's George's line. Breaking George's line. Angulation. It's greater than 7 degrees in a motor unit. It's angulation. Greater than 7 degrees. Okay, that's flexion, extension. Next. So I'm looking at the motor units, right? Because that's what it's all about. Those motor units aren't moving normal in the remodel phase. At MMI, 2 re-exams, that's called MMI and it's permanent. So, got the motor unit. What else are we going to check? Alar ligament. APOM,
Lateral flexion.
right lateral flexion, left. Checking for lateral mass movement. That's especially movement in personal injury if the person has been T-boned. What else are we going to check? AP, cervical, left and right lateral bending. Maybe AP is, remember, the mouth shut, chin up. Right lateral bending, left lateral bending. What are we looking for there? Cervical rotation. We're looking at that spinous process. In the neck, when you bend to the right, what does that spinous process do? Go to the right or to the left? Goes in the opposite direction. What if it stays neutral? Good or bad?
It's fixated.
What if it goes in the other direction that it's supposed to? Real bad. Am I going to quantify it?
Yes.
How am I going to quantify that?
Functional capacity.
Mild, moderate, severe. I'll go pathological, rotation, mild, moderate, or severe.
Gotcha.
If it's neutral, I'll say maybe mild. If it's a little bit to the right, I'll say moderate. If it's rotated a little more to the right, I'm going, that's severe. That's a major biomechanical problem. That's going to cause serious degeneration, nociception, intrinsic muscle spasms, pain, ADLs. The whole blown osteoarthritis thing is going full speed ahead.
Yeah.
That's the neck. And then what's the neutral ones we're going to pay attention to? Physiological line of stress,
Lateral.
cervical lordosis. Not as big because they're static.
Right.
It's neutral. Low back, we're going to pay attention to flexion extension. Not with a low impact injury. Head-on collision or major injury we will.
Okay.
Right? Because that's thick anatomy and there's no whiplash effect, right? So where am I going to find most of the problems with injuries in the low back or low back pain?
Lateral bending.
Lateral flexion. So it's AP, right lateral flexion, AP, left lateral flexion. What am I looking at? Motor unit lateral flexion. Uniformity of motor unit lateral flexion. What else am I looking at?
Rotation.
Rotation. Now in the low back, I bend to the right, which should happen normally with that spinous process.
Goes to the left.
No, it goes to the right. It's the opposite of the neck.
Okay.
So right, and if you go to the right in the low back, it should go to the right. You go to the right and it stays in the middle, is that pathological?
Yes.
That's I'm going to call that mild. Let's say you bend to the right and it now goes a little to the left. That's moderate. You bend to the right and goes quite a bit to the left, that's severe. That's severe pathological motor unit rotation.
Proprioception is gone, huh?
That's bad news.
Yeah.
Now, as a chiropractor, I see that on the exam. Is that important to me clinically to treat those units?
For sure.
Yes. How important is motion x-rays for physical medicine in the repair phase of healing?
Got to know where to adjust.
Huge.
Yeah.
Huge. Now, what else will support that? So the x-rays are like the best, right? What else is going to be clinically significant?
Palpation.
Symptoms, will they have symptoms? Yes. Symptoms doing what? Neutral or movement? Movement, and which movement?
Plane of injury.
In the plane of injury. What else? What else will I typically see? Palpation. Am I going to see a fixation there?
Yeah.
Oh yeah. Am I going to have tenderness there? Oh yeah. Am I going to have muscle spasm? Oh yeah. What are the common biomarkers? Positive symptoms with dynamic movement. X-ray. That's like real definitive, right? Fixation palpation. Tenderness palpation. Muscle spasm palpation. When you get into personal injury and you're looking to do MMI, now we're going to seal the deal with the Dynarom. Now we're going to measure it. It's 100% objective and it's permanent. When you do the Dynarom at MMI, now you have an objective test, muscle, permanent. It's primary for muscle, secondary for altered pathological spinal movement. See how this all comes together?
Yeah.
See where you need to focus? Is this good stuff or what?
Yeah.
Why do you think I have not treated a patient in 25 years? Do I look a little excited? Do I sound a little excited?
A little bit.
Why?
Because it works.
Is this great stuff or what? This is great stuff. You know how many people you can help? You know how many people are not, you know how many people are going through this and are not being helped? These are all the people going to the emergency room, the general practitioner, getting ibuprofen, Motrin, all these. That's that massive amount of people that are not seeking chiropractic care. That's out of the 92%, 3 out of 4 of them are going through this process. And guess who's there to help with the most important part for those people? The repair phase of healing, physical medicine, and active passive and joint motion. Guess who's there for them?
Us.
No, they're not seeing you.
All right.
They're skipping this, and what are they going to?
Instacare.
They're going to the #1 disability in the United States. 1 in 5 Americans has osteoarthritis. That's the #1 disability in the United States. It all started from here. They didn't get, and the most important component was right here. This is important. Medicine will take care of this, right? The inflammation phase. Okay, they couldn't even see a chiropractor here and they'd be okay, right? How important is chiropractic care here? It's vital. Who else is going to give them the joint motion? What's the most important motion? The joint motion, the fulcrum. This is important, but this is more important than this. So it's nice if we could get them this and this. That's like the best. That's like the best care. You know, do a little with inflammation in the beginning, get their joint motion back as much as possible and increase the strength and elasticity. That's like the best care at MMI. And so that's the total goal. The total goal in the best care is all of these tests are normal at MMI in the plane of motion of the injury. That's the best outcome. The worst, you just treat them for symptom care in the neutral position and you let them go. You just guaranteed this person some degree of permanency. How much is the question? It could be not enough to be threshold, right? But what do we know? 2, 3, or 4 of those, and now they're threshold, and now they're one of the 4. They're one of the 5. 2, 3, 4, 5 years later, they're one of the 5 in disability. They're the people taking the ibuprofen, Motrin, aspirin like candy.
Because they have multiple injuries, most likely.
That's right. Yeah. They're multiple sub-threshold injuries that eventually become threshold. Yeah. How important is your role in this whole thing? It's huge. There's massive business out there. Bad news is you got to know marketing because the branding of chiropractic is terrible.
Yeah.
Can't say you can be everything to everybody and get business. That's when people see you as a kook. When Taco Bell tries to sell computers, that's when you look at Taco Bell and you go, they're kind of kooky. And then you don't even want to get tacos from Taco Bell. And that's what the population does. The vast majority of mechanical problems or spinal problems are not seen by chiropractors. They're seen by general practitioners. The chiropractic profession is not the leader in any one singular health industry. After 120 plus years, 8% utilization, 67% negative name recognition, even though the masses amount of people are getting micro injuries, minor traumas, major traumas. They're going through this whole cycle every day, every week, every month, and they're ending up over here. But they're not going to chiropractors because of terrible branding.
Terrible care?
Terrible branding. Here's the good and bad news. There's 3 types of marketing. There's publicity, advertising, and educational sales. Publicity and advertising only gets patients who are looking for a product or service. The bad news is that's only 8%. And then you're limited by your geographic radius of draw, and you're dividing it with your other competitors. That's the bad news with chiropractic. The great news with chiropractic, out of the 92% that do not seek chiropractic care, 3 out of 4 of them have a chiropractic problem to some degree. Back pain, neck pain, joint pain. 1 in 5 has joint pain as a disability. Back pain, neck pain, joint pain, old injuries, car injuries. If you just looked at those and nothing else, sciatica, you don't even consider anything else. Massive amount of people. You got more patients driving by this office every day going down to that local medical doctor with back pain than they're calling in here. Thank you branding chiropractic. That's the problem with the subluxation. Subluxation says it can do everything. Asthma, allergy, bedwetting. That's like Taco Bell saying they can sell computers. And that's why it's at 67% negative name recognition, 8% utilization. The great news is if you knew educational sales, that's what gets that group over here. The massive amount of business, that's 68% of the population. That's what gets that population as new patients. Educational sales. Works great. But if you don't know it, you're stuck. And 95%, 99% of chiropractors don't know it. They're stuck fighting over the 8%. And then they're constantly buying new gadgets to try to get new business. And then knowing how to keep the patients. How do you do patient education to get this across to them so they want all three phases of care, and then you make it affordable? Well, you just significantly decreased your new patient problem if you know how to do this and keep the patients through all three phases of care. And by the way, clinically, it's the best thing you could do for them. You just significantly decreased, easily by half, the number of new patients you need. All these chiropractors that are screaming for new patients, new patients, new patients, half of them don't even need new patients. They're losing patients left and right. Kind of like you guys who looked at your stats. You're losing over 50% of your patients by the second or fourth visit. Didn't even know it until we looked at the stats. You thought you needed more new patients. So first you got to know how to keep them. Because how smart would it be to lose 50% of your patients by the second or fourth visit and do marketing to get more new patients? To spend money and time to get new patients. How smart would that be? That'd be called stupid. So the first thing you have to do is know how to keep them. As soon as you do that, your business comes up and you need half as many as new patients, generally speaking. And some people don't need any more. Sometimes you have doctors like you seeing 25, 20 new patients, but you're losing so many of them, you're only seeing 80 visits a week. I mean, it's like unbelievable. You would need an associate doctor. If you actually knew how to keep the patients, you'd be seeing 80 to 180 to 200 and your associate doctor. I mean, you could see 150, your associate doctor would be seeing 100 with 28, 31 new patients a month. If you know how to keep them and process them through. Well, that's what we're doing. So there's a huge difference. There's a huge need. They're just not looking for you. So with chiropractors, generally they don't know this. They don't know how to communicate it. They lose a lot of patients. Then they're fighting for the measly 8%. And that's why you have over 50% of chiropractors not practicing 5 years later. And there's a massive amount of business. So here I learn all of this. And I have 2 full-time associates seeing 350 visits a week, open 77 offices in 20 states, seeing 600,000 patient visits a week. But 52% of those doctors had gone bankrupt because they didn't know how to do any of this. Well, once they learned how to do this, we reopened them and bam. Because there's a massive amount of business out there. You have to know how to keep it first, then how to get it, educational sales. That's the 1-2 punch. Everything else is secondary. There you go. That's the solution right there. It's fantastic. Great. It's a great service to humanity. You're helping a lot of people with their life. You're getting paid well. It's a good lifestyle. I mean, where else can you take a 2-hour vacation, work 4.5 days a week? What other kind of job? And then out of the 8 hours that you actually do or in a day, it's only really 4. What other job can you do that? Oh, and by the way, it's safe. You're not exposed to bullets or rockets like some countries right now. You're in a climate good environment. You're not out there in a telephone pole in the snow. See? When you know how to do it, it's fantastic. That's why I can sit here 25 years later and never touch a patient 25 years and be excited as hell. That's why.